I will continue with things which are far away from AI, but I think this is also important to have this biological things to improve our treatments. This is most for hemorrhagic stroke. And first of all, I would like to thank the organizers for this meeting and session. And we are sorry that Adnan Siddiqui could not be live with you, but he sent us also a recorded presentation that we will have just later. So my talk is about biological optimizations for flow diverters, and we should just remind that we are not just a brain plumber. And when we present ourselves in our profession, we often say, I'm the plumber of the brain. But we should remind that, first of all, when we have an aneurysm, it's because there is a biological disease, and this disease leads to rupture in some cases. We can observe in the arterial wall that there is a thickening and of the arterial wall. There are few smooth muscle cells. There is also rupture of the intima, and this could lead to rupture of the aneurysms. But unfortunately, we are still plumbers, and whichever the treatment we use, either clip, coils, or even with flow diverters, we are still plumbers, and our aim is to seal the hole and reconstruct normal arteries. This should be the aim, but when we do open surgery, the neurosurgeons do better than what we can do with endovascular, because with the clip, there is a realignment of the normal artery covering the neck of the aneurysms with normal artery. But when we put coils inside the aneurysms, we did not treat the defect, the arterial defect. And even when we put flow diverters, we do not treat the defect, the arterial defect. And we aim that our treatments, either coils, flow diverters, will reconstruct the normal artery, but it takes time. And when we look at the results with flow diverters, we have a few meta-analyses. The first one was in 2013 by Walid Brinjigji. We reported that there was a 76% total occlusion at 6 months, which was considered good because the flow diverters were initially indicated for large or giant aneurysms, which were very difficult to treat with other options. But at 1 year, we had this results in 2016, with 77% total occlusion at 1 year. And recently, with the pipeline chill technology, Medtronic published the INSPIRE registry with a 1 year total occlusion rate at 79%. So the results are not improving a lot since the first meta-analysis in 2013 and the most recent ones. And there is still a glass ceiling, which means that in 1/4 of our treatment with flow diverters, there will be a treatment failure, which is a real limitation. It would be very inappropriate to have a $10,000 treatment which failed in 1/4 of cases. So there is a need to improve and to break this glass ceiling and to have greater results with flow diverters. And this is why we try to optimize these results based on the biology. So most of biological studies performed in the aneurysms field are based on the elastase model in rabbits. This is a surgical model where we have an introducer into the right common carotid artery, and then we infuse elastase. Elastase will destroy the elastins fibers of the artery, and 3 weeks later, after the ligation of the artery and the arterial injury with elastase, we can observe aneurysms which are about 8 to 10 millimeters and quite similar to saccular aneurysms in humans. And when we look at the healing mechanisms of flow diverters, we can see that initially, before the treatment with flow diverters, there is this aneurysms, which is largely patent. After the flow diverters, there is a flow reductions. And at 1 month, what they observed in the first studies in 2009 was a coverage of the meshes of the flow diverters with a neo-endothelialization, a neo-tissue covering the meshes of the flow diverters, allowing to exclude the aneurysms from the circulation. And you can see in the very first days, we observed that the flow diverters is totally naked inside the artery, and there is absolutely no tissue covering the flow diverters between the arterial lumen and the inner part of the aneurysm. I hope you can see my arrow. After 3 months, we can see that there is a tissue covering the flow diverters and a progressive exclusion of the aneurysms from the circulation. But this process takes time, and it comes from the normal arteries surrounding the neck of the aneurysm. And you can see these arrows with the green tissue. This is immunohistology with the CD31 markers. CD31 is showing the endothelial cells proliferating over the struts of the flow diverters in order to cover the neck of the aneurysm and exclude it from the circulation. So it comes from the normal arteries surrounding the aneurysms, but what we observed is that in 1/4 of our treatments, there is not a total occlusion of the aneurysms, which means that there is a need to increase and accelerate the endothelial cell proliferation in order to increase the rate of success of our treatment. Maybe the first biological options is to have a good wall apposition. If there is not a good wall apposition of the device at the level of the aneurysms, there is for sure no tissue which will be able to proliferate over the struts of the device. You can see here, this is in the rabbit model. There is no apposition of the device at the level of the neck of the aneurysms. That's why there is no tissue over the struts of the device, and the aneurysm is still patterned. But in case of good wall appositions, then the endothelial cells which are below can proliferate over the struts of the device, and you can see that the device here is incorporated inside the neo tissue, and the aneurysm is totally occluded. So the first options to have a biological support is to have a good wall apposition, and we observed that the odds ratio was about 16 times. And this has also been confirmed in some other studies, here with the OCT analysis, where they reported that wall apposition is more important than pore density for aneurysm occlusion. So this is a real problem, because when we look at new devices, each industry or each laboratory tries to have a better device, a new device which will be better thanks to a greater meshes and higher mesh densities. This is probably not a goal and something where we should go. First of all, we should be sure that when we oppose our device, there is a good wall apposition. So which are the aneurysms to treat with flow diverters? Initially, flow diverters were indicated for large or giant and ruptured aneurysms, and mostly in siphon. And flow diverter in these options had very good results. Even in 76% of cases, we had these results which were not possible with any other technique for these large or giant and ruptured aneurysms. But today, when we look at the INSPIRE registry, aneurysms which are treated with flow diverters are small aneurysms in 46% of cases. There are distal aneurysms in 15% of cases. Most of them are unruptured or previously ruptured in 20% of cases. And the aneurysms which are acutely ruptured with flow diverters are 2.7% of cases, which means that we moved from large or giant and ruptured aneurysms to small distal aneurysms, which are easy to treat with other options, either coils, stent and coils, many other techniques, and with results which are sometimes better than with flow diverters. And when we look at the morbid mortality with flow diverters, we still have 1.6% death, 1.9% intracranial hemorrhage, and 3.7% stroke, which means that this is not very. There is a risk using flow diverters, despite the dual antiplatelet treatment. So this is one of the limitations of the flow diverters using dual antiplatelet treatment, but it will prevent against stroke. So is there room for flow diverters in ruptured aneurysms? We often hear that industry claim that their new flow diverters will be able to treat the ruptured aneurysms. We have plenty of other options. For sure, there is surgery, but even endovascularly, we can use coils, we can use balloon-assisted coiling, we could use endosaccular devices. We have plenty of other options with great success, with not even a single antiplatelet treatment. So why should we run for using stents and flow diverters in ruptured aneurysms? Maybe the only exceptions for which the flow diverters are indicated are blister aneurysms, but we need to remind that they represent only 5% of ruptured aneurysms and only 0.3 to 1% of intracranial aneurysms. So, should we design devices for only 1% of cases? What is the risk while using dual antiplatelet treatment in our patients? The only data with dual antiplatelet treatment rely on the cardiologic fields, but we have no data regarding population without comorbidities of our patients. If we decide to put flow diverters in a 40-year-old patient with no other comorbidities than his aneurysms, the risk of using dual antiplatelet treatment is probably very low. And most of data come from cardiology, but patients in cardiology have many other comorbidities. So it's very difficult to compare these results with our population. In the Plateau trial, they included more than 18,000 of patients with acute coronary syndrome, and they observed 4.5% myobleeding with ticagrelor, but their patients are older with more comorbidities than ours, so very difficult to extrapolate these results. And in the flow diverter population, what we observed with the dual antiplatelet treatment is 3% intracranial hemorrhage, and we have no data regarding major bleeding. So what is the risk of using single antiplatelet treatment with flow diverters? We have no information neither. Is there any higher risk of thromboembolic complications? Probably yes, but we don't know. And the risk is that if we go for flow diverters with single antiplatelet treatments, it's because of some new anti-adhesive surfaces. New anti-adhesive surfaces could avoid the aggregation of the platelets, for sure, but there is also a risk for delayed endothelization, because if nothing can adherate on the surface, the risk is that there is no tissue proliferation over the device, and there is a risk also for no occlusion of the aneurysm. So there is no randomized control trial yet, but the risk is that with a single antiplatelet treatment, okay, we could maybe reduce the risk of intracranial hemorrhage, but the risk is that we do not occlude our aneurysms. And there is still no comparison of coated versus uncoated flow diverters. That's why we designed the CICAFlow study in the EMIS research lab in Limoges. And we compared 3 different flow diverter stents in rabbit aorta, either the Silk Vista without any coating, the pipeline shield, which is coated, and the surface valve with no coating. And we test them in 3 different antiplatelet regimens, either no antiplatelets, either aspirin alone, or aspirin and ticagrelor. And we used 27 different flow diverters within 9 different rabbits, and we implanted them in different organizations. Then we evaluated with OCT, advanced histology. We also did the flat panel CT and some advanced microscopy that I will share with you. So the primary results, it's the first experimental study using ticagrelor in rabbits. And this is important to notice that it's not so easy to give this medication to rabbits and to have the results, but we observed no case of acute stent thrombosis. We observed no case of clot on the flow diverter surface. And we are still currently doing the quantifications, but I will share with you the first results we have, either here in the aspirin alone group at 1 month. And when we look at the OCT, either with the surpass, the silk, or the pipeline shield, what we observed is that there is a huge range of underutilizations. When we look at the surpass, you can see that the struts of the device are incorporated inside the arterial wall. Same with the silk, with a greater near-underutilization over the device. You can see that the struts are quite far away from the inner part of the lumen. But when we look at the pipeline shield, you can see that there is no tissue covering the struts of the device. So there is a delay in coverage with the pipeline shield. So maybe we can also do underutilization speed analysis, and we need to have struts by struts analysis. But what we observed also with the electronic microscopy is that when we look at the silk, we can even not see the meshes thanks to the near-underutilizations. There is a new artery covering the struts, and we don't even see the struts. With the surpass, there is a tissue coverage which is almost everywhere and uniform. But when we look at the pipeline shield, we can see that the struts are most often bare. So also this is what we observed with the multiphoton microscopy, which is something which is very specific to our lab. We can see that with the surpass, we can see the meshes, but the tissue coverage of these meshes. On the silk, we cannot even see the meshes because there is the tissue which is very thick. And with the pipeline shield, we can see that the meshes of the device are not covered at all. So it confirms also that there is a delay in this case. We could also see that on the histology here with the Masson trichrome or the oscillate. So this is just preliminary results, and we need to analyze all the stents with quantifications. But what we observed that there is a variability according to stent deployments, probably variability according to different stent areas, and this is not a uniform coverage, but this needs to be confirmed and to see if in humans it would be the same mechanisms. And maybe there is an impact on aneurysm occlusions, but this needs to be demonstrated. But these results should make us questions about the risk of using unadhesive coverage. So which should be the ideal stent or ideal flow diverter? These ideal flow diverters should treat our aneurysms in 100% of cases, which should not be happy with only 76% total occlusion at 1 year. So we should have a stent with a fast healing and accelerated proliferation of endothelial cells and smooth muscle cells. This stent should have antithrombotic properties to avoid the clotting inside the device, and also antineutrophilic properties to avoid the activations of neutrophil. And all those properties, fast healing, antithrombotic, and antineutrophilic, are the ones which are conferred by the CD31 in normal vessels. If you have an arterial injury, it will heal by itself very fast. There will not be any thrombotic activation or neutrophilic activation in normal vessels. So what we aim with our new project is to have a stent which could mimic the normal arteries. And we developed this CD31 and a mimetic of CD31, which is called P8RI, which is patented in our lab. And we grafted this P8RI peptide on the device, the SILK device, in collaboration with PALT, in order to favor fast cell proliferation over the device and also to inhibit neutrophils and platelets activations. Those results have been recently published in Stroke, and what we observed is that there was faster healing thanks to the P8RI compared to the bare group, and also neo-endothelialization over the straits of the device. We also observed, this is the right column, that the device is very well incorporated inside the neo artery, and you can see that there is a neo endothelialization covering the structure of the device with a single layer endothelial cell and also with smooth muscle cells. So with the P8RI grafting on the silk vista, it can transform the flow diverter in an active barrier similar to normal artery. Thanks to faster endothelializations, we could probably stop the antiplatelet treatment much earlier than without this P8RI coverage. And I think this is a greater option to interrupt the dual antiplatelet treatment very fast than going for a single antiplatelet therapy. So we should rather focus on 100% total occlusion, and there is still room for improvement of our flow diverters, because what we observe, despite smaller aneurysms which are treated with flow diverters, probably more easier aneurysms treated with flow diverters today, we did not observe a higher occlusion rate. There is probably no need to run for flow diverters in ruptured aneurysms because we have other options, and dual antiplatelet treatment might be deleterious, but there is absolutely no evidence that single antiplatelet treatment is safe while using flow diverters. So we should probably rather focus on fast healing, and this is the we need to do experimental research every time and to validate those concepts. That's why we need, and as a doctor, we need to be very involved in the research field in order to go in good options. That's why we, with Charbel Mounier, we developed this experimental platform in Limoges, and this is a GLP laboratory equipped with a brand new Icono Angio suite dedicated to research in animals in the interventional neuro field, and we would be very glad if you have research also to share together. So I would just like to thank you very much for your attention, and if you have any question, I would be very happy to try to answer.